Good evening, everyone. Welcome back to our Exam Pro webinar series for the 2021 ABOG Oral Board Examinations, our first month of webinars for case list defense and structured cases. Tonight for Thursday, August 19th, 2021. I'm your host for this evening, Rob Pegues. Thank you to all of us who are joining, all of you who are joining us for our rescheduled webinar this week. We'll continue this week with our review of structured cases as we do each Monday and Wednesday generally. I've assembled for this evening a set of new cases. We'll rotate OB/GYN and office practice to sample all the different areas of the board exam. And we'll get started right away since we have at least 5 of our attendees up and ready to go. We'd like to give everybody a chance to participate in discussing these cases, and we'll try to get everybody's mic open so we can have a group discussion. Since we are present, we're a fairly nice small group for the evening. Do remember, please just click the raise your hand button, as Dr. Benda has just very nicely done. If you'd like to participate, I would be very happy to call on everybody who would like to chat, and we'll give everyone as much time as we can this evening. Do remember, you can just move your box to right and left. I think everybody has a mic and speaker, so we don't have to worry about the telephone here, and we can get rid of all that and just get on to our cases. Let's see. So let's start right off with our first case. Let's see if we could get Dr. Benda first, and then maybe Dr. Jones. Ashley, can you hear us okay?
Hi. Yes, I can hear you. Can you hear me?
Great. Yes. Oh, we're good. Thank you. Yes. Let's start in. So we'll be doing OB/GYN and office practice. So our first case is going to be an OB case, if that's okay.
Absolutely.
Okay, so first of all, I'm just going to run through very quickly. I think you guys already know this. The structured cases are sort of a very brief clinical problem. Sometimes they'll actually give you just a specific question, so almost like a CREOG kind of book-leaning question just to test your knowledge, and then they'll develop a scenario from that. Usually we'll be asked things like, what could be going on here? What's our differential diagnosis? What would you think of first? And then we'll proceed to a very brief discussion of sort of how we would evaluate with history, physical examination, any testing and studies. And then quite often they'll define the question as some particular problem. So if we're talking about hypertensive disorders of pregnancy, maybe they'll make the last part of the question about preeclampsia with severe features or something like that. And finally, a possible follow-up question. I try to put as many of these in as possible, and they do occur in quite a number of these structured case questions. I'm going to show these in red font on our screen. In the actual examination, everything is in black and white, and you'll be able to tell what's what. But the follow-up questions come in a couple different forms, some of which are just sort of extra credit, where they're going to ask you sort of picky knowledge, and if you happen to know the answer, that's great, and if you don't, there's no credit taken away. And some of them are how we'd manage particular situations, and they probably actually do have some importance or pass-fail value. And as we go through here, I think we'll begin to become very good very quickly at sort of figuring out which types of the Part D questions are there. So let's start in with Ashley. We're going to do an OB question first. You are having difficulty delivering the placenta following an uncomplicated term vaginal delivery. Part A, what is your initial management? So this is very characteristic of, I'd say, about a third of the questions on the exam, in that there's really no specific information here. We don't know the patient's age, parity, anything else about the pregnancy. It's just she had an uncomplicated vaginal delivery, and we're having difficulty delivering the placenta. Difficulty is a very sort of nebulous and non-specific term. So this question could go anywhere. So Ashley, you can start and take this anywhere you'd like to go.
Okay, so well, immediately following delivery of the fetus and cord clamp, I start Pitocin infusion. So that should be already going. We do have 30 minutes to deliver the placenta. So some things that I can be doing could include like a fundal massage. Those are typically what I am doing, as well as inspecting the repair and making sure the patient's stable.
That sounds good. Great. Sounds terrific. We can actually just stop right there, because I think in the structured case question, the idea is to sort of parse our answers out. If we sort of start talking and we just run on, in caseless defense, the examiners will sort of cherry pick one little thing we say and sort of take it off in a very different direction. In the structured cases, this is really much more of a monologue. There's not near as much interaction. And if you start talking and you just sort of start to run on, the examiner will sort of interrupt you and just click to the next part of the question, which will be a little disconcerting. So it's nice to start where Ashley did. And I think what she has discussed is what she would be doing in the first few minutes here. Sometimes initial management is just what you're doing in the first 60 seconds. I think that's actually excellent. So that was nicely said, and I think that was nicely structured and nicely focused. Good. Oh, now, if you suspect placenta accreta, how you manage this situation? Note that all of a sudden, this has completely changed its color and tenor here. So now we're concerned about a fairly high acuity situation, whereas it was just very unspecified before. So Ashley, if they now drop this into your lap, how would you sort of shift your management here?
So if I suspected a placenta accreta, I would not try to remove the placenta at all. We would
Good.
leave that in situ. And I would be discussing the situation with the patient and also assessing the situation, because one of the things that we get very concerned about is bleeding with accreta.
Yes.
So I would be doing a very thorough assessment of how her bleeding is to decide how we can proceed.
Great. Is there anything else you might do upon sort of it popping into your mind? Oh, I think maybe this is a placenta accreta, and maybe just sort of any preparation you make for whatever your continuing management is going to be in this case.
So I think it's always good to make sure that you have adequate anesthesia for the patient, that you have an IV in, you know, and that she has a Foley in.
Sounds good. If you suspect a placenta accreta, and I think we're still in the labor and delivery room, and you've been sort of working with the placenta. If you suspect a placenta accreta, are you going to change in any way sort of where you're going to be managing this, or what resources you'd want, or sort of where you might go with this?
So I imagine that her bleeding is not good, or that she's having a lot of bleeding, and so we would likely be moving to the OR in this situation.
Sure, that's fine. No, it's not specified whether she's bleeding or not, but if you think about it, it sounds like this may become a surgical case at some point, and that's reasonable. What we would suggest, and we've discussed this in our week-long courses so far, and I believe here, this is something we should just commit to memory. We just call it getting all your ducks in a row, and it's just 5 fingers on one hand. The first thing, and in any acuity situation like this, in the exam, in caseless defense, or in a structured case, where suddenly the acuity level goes up, like you're just talking about your hysterectomy, and all of a sudden something, you know, a uterine artery pops loose and is bleeding, or you enter the bowel, or, you know, an OB, something like the Osana, you had a uterine inversion or something like that. It's good to stop and just do these 5 things as far as getting our ducks in a row, and it covers any situation. First of all, notify everybody. So you're going to tell nursing, anesthesia, any intensivists you have around there, OR staff, anybody you need to, that we have a potential emergency and we need to start preparing for it. Number 2 is get yourself an assistant. So just get partner, colleague, resident, anybody else who would be helpful to you in having 2 pairs of hands. Numbers 3 and 4 are labs and blood bank. Just, do we need to do any laboratory studies right now? Should we, for any reason, notify the blood bank and start making preparations? And number 5 is patient counseling. Discussion, informed consent, which in a case like this you could do in the middle of a surgical procedure, sort of letting the family know that there's an unanticipated complication. But we would like all our candidates to commit these to memory, to practice these, because in the exam, when they suddenly drop this at you, and sometimes it's more acute than this, like suddenly a shoulder dystocia is happening, it's very tense, and it can be emotionally traumatizing because we really feel this is a real situation, and it helps to back out of it for a moment, take a deep breath, and just spout off those 5 things we memorize. Notify everybody, get yourself an assistant, labs, blood bank, patient counseling. And then you can re-engage, and you're sort of more focused. And it also tells the examiner that no matter what, you're going to start making preparations. And that's just a nice, quick set of things to run through, and just sort of pick whichever ones are really important to the situation. So I agree. I think we need to be going to the operating room. I think we want to marshal some support. Any laboratory studies you want to get just at the moment?
I certainly think it would be a good idea. I would assume that she already had a CBC and a type-in screen on, so we would probably get a type-in cross. Right now, it would not be a bad idea to just draw another CBC or an ISTAT to see where she's at.
Good. Do you want to have the blood bank involved in any way at this point?
They should be aware that we may be activating the massive transfusion protocol, just because that can take a bit of time. So.
Sounds good. Great. Sounds good. Let's move on then, 'cause I think you've nicely set us up for where we're going to be going here. Let's see what C is. What will be your steps of management in the OR? So they pre-anticipated that we are in fact going to the OR. So now we're in the OR. We have assistants, instrument tables, anesthesia, partner resident. Everybody is in there. We've got the patient on the table. We've got probably up in footrest. We've got great exposure. So can you walk us through sort of step by step how you might now manage a suspected placenta accreta in the OR? And again, nobody has mentioned bleeding here. Interestingly, the word blood does not appear anywhere in this case list so far. So you can sort of take it to be bleeding or not bleeding as you'd like to, but they haven't gone there yet.
Right. That's what I find interesting. So it's, and I'm kind of like, I guess if she wasn't bleeding, we would just leave it as it is and make
Yeah.
sure that her bleeding is well controlled and
Mhm.
maybe watch her for a little bit just to make sure that we're doing okay. So that would be an optimal situation, honestly.
Okay. Okay. So she's not having much bleeding. You're going to watch this. How long would you sit and watch a placenta if it might be an accreta?
So my understanding with this is that we really have to have counseling with the patient about what she
Yeah.
wants. Does she, is she okay with having a hysterectomy? Okay, well then that's an easy decision, right?
Yes.
But if she is really, if she's really trying to conserve her uterus, I have never had this situation, but I
Mhm.
do believe that there is a way to possibly with methotrexate and some very intense, frequent management, possibly allow this, as long as she remains stable, to be managed
Mm.
kind of expectantly. And then,
Okay.
yes.
Okay. I think in this case, if you went there, the examiner would say, "Well, suppose she's actually bleeding. What would you do?" Because I think
Hmm.
they want us to be managing this more acutely. You're actually right. There are cases when that can be done. They're not as common as we might think, but it's an option out there. But if we sort of understand that we have to kind of at some point pretty shortly get the placenta out in some way, what would be your sort of step by step by step? What would you go through as far as potential interventions to resolve the situation?
So, so the patient is bleeding briskly, and that is why we're going to the OR.
Well,
So,
she's bleeding at least moderately, let's say. She's having some bleeding. It's not really stopping. So the pressure is on to us to resolve the situation sooner rather than later, I think.
okay. So again, I would not be looking to remove the placenta. We would be, um, as I said, if you're worried about bleeding and you want to manage her bleeding, yes, you could do urotonics. You could do
Okay.
operate if you needed to, but um, if you're really concerned about a placenta accreta and her bleeding is starting to pick up, then the definitive management is to open and do a
Mhm.
hysterectomy.
Okay, sure. Now it says if you suspect placenta accreta, I'm not sure how you suspect that. I'm wondering if perhaps along the
Agreed.
way you went up in the uterus and sort of to see if you could manually separate the placenta, and you really found that it seemed to be highly adherent, and that raised uh, your antenna very high. Maybe that's what was going on. Possibly so.
Okay.
So in this instance, you think that rather than proceed further vaginally, we're going to move to a laparotomy?
I would,
I'm good.
if I'm
I'm
worried
good with
about
that.
placenta accreta, I'm not going to touch it. I could
Agreed.
consider, while we're in the OR, having the bedside ultrasound
Yes, sounds good.
brought over to take a look
Yeah,
at it from an
yeah,
ultrasound perspective.
yeah.
But yeah, I don't play with placenta accretas.
Yep, that sounds good. So, very quick, we'll sort of move this along. Vertical incision or phanastile incision?
So, for best exposure, a midline vertical
Hmm.
would be the
Okay,
way to go.
okay. Could you do a phanastile incision in a case like this?
You certainly could.
We could.
If this
We
is a
could if we're.
surprise
Mhm.
case, though, I would say, what else? If this is
That's
completely a
fine.
surprise. Why is it such a
Sure.
surprise? And what else are you going to find when you go in?
That sounds reasonable.
I
Sure.
try to avoid that T-shaped anchor incision whenever I can.
Of course, agreed. Okay, so vertical midline, we're going in. Now we've got in the abdominal cavity uterus in front of us. What will we do next?
So baby is already delivered.
Yes, exactly.
So here we would be moving forward with the hyst, assuming we'd already done our inspection of the rest of the abdominal contents and
Sure.
have an idea of whether there's any bowel or bladder involvement.
Right. So you're going to go to a hysterectomy?
I'm not familiar with any other options for managing an accreta where we're in the abdomen, and because we think her bleeding is not
Okay, that's fine. Let's bring a partner in. Let's get Dr. Jones in here. Ebony, if you can unmute yourself, let's bring Ebony in here for a minute. Try to get Ebony to unmute here. Whoops, Ashley, I lost you. I'm sorry. I'm trying to get you unmuted again. Ashley, come back if you can. Oh, there you go. Ashley, you're back. Good. Let me see if I can get. I'm trying to get Ebony unmuted. There you go. Ebony, we got you. You can hear us okay?
I can.
Good. Okay, so you and Ashley are partners in the operator co-managing it. Anything you'd like to add to what she's done so far? I think Ashley's walked us through this case very, very nicely so far. We've stayed safe, patient's okay. We have all of our resources marshaled, and now we're going to come down to taking care of this.
I think Ashley's done a great job. I agree with pretty much everything she said so far. And I also, at the time of the abdominal incision, would look to see if there was any other evidence of percreta or increta, make sure that there were no other tissue involvement. And I would also try to look at the uterus before opening it to see if there was any indication that there was an accreta.
Okay. Now you said looking at the uterus before opening it. Are you thinking about doing something before you proceed to a hysterectomy? Because it sounds like Ashley is going to go ahead with the hysterectomy here.
If she's stable and controlled, I would probably try to do, and we're determined that we're going to go through with a hysterectomy. I would, if we can, do an umbilical artery embolization and try to decrease the blood supply to the uterus prior to surgery.
Okay. All right. If this is the patient's first pregnancy and delivery, and she really desires future fertility, would you consider anything short of just going to a hysterectomy in this case? Just asking.
If she was committed or really desired maintaining her uterus and she was stable, I may put an intrauterine balloon in, maybe to help compress and stop the bleeding if that were present.
Okay.
Can't really think of, I personally haven't managed it, an accreta externally. I've only done hysterectomy. So I don't know, other than the methotrexate, which was mentioned previously, what other options there are.
Any thought for actually opening the uterus and seeing, while you have the uterus open and you can control it and get the blood supply right away, opening and seeing if you could actually remove or curette out the placenta? Just a thought.
I wouldn't.
Okay. Ashley, yes or no?
No,
Nope, we're not doing that. Okay, that just brought it up.
Yeah, no, I would not. I have seen other people do that, but I do not do that.
That's perfectly okay. The examiners are just interested in your particular hands. How will you safely take care of this patient? That is perfect. Good. So it comes to, at what point would you perform a hysterectomy? There, depending on what is going on here and your sort of degree of uncertainty about this, there can be a role for doing a hysterotomy and doing an exploration, at least to identify whether it really does appear to be a placenta accreta, or maybe you get in there and you may find that, in fact, you can find a really nice dissection plane and it actually is very easy to remove the placenta, and you would have then saved the patient a hysterectomy. So in a case like that, doing hysterotomy simply to examine without necessarily operating on the placenta unless you feel you have a clear indication is something you could mention, especially if the patient sort of really desired fertility. But agreed, if your impression on opening the uterus and looking was that this appeared clearly to be an accreta situation, both of you are correct. I think you would go straight to the hysterectomy. Cool. And that's that part. This part D is really an important part D. This is one of those accounts. So Ebony, Ashley, thank you for doing that. Any questions or anything you'd like to add to this before we go on? And maybe Evan, if you'd like to stick around, you can start our next case for us if you'd like.
Okay.
Ashley, how are you feeling?
Yeah, good. Is there anything else that should have been done before hysterectomy? I felt like
No,
I
only
was
depending on the patient's sort of, her fertility concerns and sort of how sure you are this may or may not be, or whether it's uncertain. The hysterotomy is the only other thing. It's really the examiners
okay.
will push you in the exam to see if you want to go up into the uterus and try to pull the placenta. It's not a good idea if we think it's an accreta. You resisted that, and they will push you on it just to see if you'll bend or not. So the important thing is when you really feel certain about it, stick to your guns on that. They do push you just to see if you'll cave. And I think you did a great job of that. You didn't cave. That
Yeah,
was
it
good.
sounds tricky because you would want to evaluate to make sure that it was an actual accreta, but by doing
Yes.
so, you might have to make an incision and even attempt to remove the placenta, which
Yeah.
does
Yeah.
not sound like fun.
Yeah. No, I think
Doesn't sound like
everything
fun.
we said here is nice. Now, I think if you could actually do a phalansteal incision in this case, just very briefly. I mean, the uterus is down at the level, it's below the
Sure.
umbilicus. It's sort of like when you do a C-section. You can exteriorize the uterus if you want to. That's an option. Vertical midline or phalansteal is fine. That was really a minor point. Nicely done for our first outing. We spent a good bit of time on that, but that was well done because this is a case that sort of develops from almost nothing to a really critical situation quickly. Ashley, thank you. That was very nicely done, and your discussion and your sort of focus and structure in carrying on the answering and your exam technique is actually very nice. That was nicely done.
Thank you so much.
Thank you. Ebony, do you want to stay around and start our next case, and then maybe we'll pull one of our other candidates in to work with you?
Sure.
Okay, this is going to be a GYN case. You are called to the PACU to evaluate a patient with oligouria following a TAH-BSO. Now, in these cases, the route of approach to hysterectomy is always important. The small amount of urine in the Foley bag has a slight blood tinge. Part A, what's our differential diagnosis here?
I'm concerned that, well, from basic to more extreme, that the Foley could be clogged or
Good. Very good.
clamped, and that's why it's not draining appropriately.
Mm-hmm.
Depending on how long surgery was, if she didn't get enough fluids, that could be a cause for her to have decreased urine output. Depending on if she had significant blood loss, that could also affect her urine output as well. And then I'm also going to start thinking about whether or not there was any trauma to the bladder. Was there a potential cystectomy? And think kind of through all those things and why there's potential blood in the Foley bag as well.
Good. Sounds perfect. So could be something mechanical with the Foley catheter. Could be that she's fluid underloaded. Could she be that she is, not making urine because she's beginning hypotensive because she has internal intraperitoneal bleeding. And you said there could be a urinary tract injury. You mentioned a cystotomy. Any other type of lower urinary tract injury that we should consider here?
There could also be trauma to the ureters as well.
Ureter, right, bladder or ureters. I think that's exactly right. Good. I think that actually covers that. That's a nice differential. And as we usually discuss in these cases, the exam pro rule is generally 5 plus or minus 1 item. So in any of these cases, if you can come up with between 4 and 6 things, that's a really nice group to start having a good discussion. And that pad of paper and pencil in front of you in the exam room is actually very useful just for sort of jotting stuff down as you're going, and that you can sort of keep yourself organized as you're working through it. But that was great. So given that particular diagnosis that you decided to develop for us, how would you now proceed to evaluate the situation?
I would go evaluate the patient in the PACU, make sure that the Foley was working properly, flush the Foley, and see if I was able to get any return, possibly even replace it if necessary. I would evaluate her bleeding down below to see if there was any increased bleeding from her vaginal area, as well as try to see if there was any, try to calculate how much fluid she received. And how much urine output she had in the OR to see if there was a deficit there as well. I would also consider, depending on if all those things came out negative, evaluate the patient vital signs, make sure she's stable, make sure she doesn't have a significant abdominal pain outside of what you would expect from surgery, and possibly get urology involved if I need to.
Okay. All right. So let's go right up to the point where you said urology involved. I think everything up to this point is fine, and we might very well need urology in a few minutes. I think that sounds great. That was the first thing is when we say how you can evaluate this problem, you can start with the basic triage and move ahead. Sometimes when we're organizing things, it's useful to say, "Oh, I'd look at the patient, and I know she's just kind of come out of surgery and she's a little bit post-anesthetic, but I'd look, does she kind of look okay, or does she look like she's getting sick?" I would immediately check her vital signs, pulse, blood pressure, respiration. So she seemed to to be okay, or is she looks like she's getting compromised in some way? Then, right, I would look at the Foley bag and examine it. I would check the Foley catheter, might evaluate and place it while I'm up in there, kind of in the vaginal area. I would definitely do a vaginal exam, look for bleeding. If I could, to sort of do a digital palpation, check the vaginal apex, see is there any sort of mass or fluctuance or something there? Does she have blood in the cavity? And then see if replacing the Foley helps. Doing the I&O, I like that very much. Looking at her input and output as best you can. That was complete. That was very nicely done. And up to this point, then the question is, if none of that really turns up anything, now what are we more thinking about? Where is this question likely to be going if all those evaluations sort of don't turn up anything obvious?
That there might have been some sort of ureteral injury.
This is going to be a lower urinary tract injury because honestly, the GYN part exam is all about the ureter and the bladder, really.
Right.
Yes, so there is no response to an IV fluid bolus, which you also tried just to see if maybe she was fluid under load. She then becomes anuric. How will you manage this?
I would try to give her medication to see if that would help increase her urine output, and then consider getting a CT scan to assess for fluid in her abdomen.
Okay, now she's in the PACU.
Okay.
So we have to take her to radiology probably to do that. And we can do that. We can certainly do that if you'd like to. In the exam, I have a feeling that if this were the case list discussion and you did
Maybe
that,
do like a bladder scan.
they would actually make her become acutely hypotensive on the way to the CT, because I don't think they want us taking her out of the optometry just yet. They would do something like that to us. I mean, you could, if you got a bedside ultrasound, you could check it, but you can also do a basic abdominal exam, I think, probably. But I think you're thinking about sort of an intraperitoneal bleed or something like that.
Yeah.
Possibly. Okay. So it sounds like you're between intraperitoneal bleed and lower urinary tract injury. Are either of those things that you can continue to manage in the PACU?
No.
No. So this is the getting your ducks in a row. Suddenly the acuity level goes up. So notify everybody, get yourself an assistant. Do we need labs? Do we need blood bank? Counsel the patient or the family. And we're going to the OR now, right? Because your differential diagnosis has just contracted to the point where we have to be in an OR to evaluate this further.
Okay.
Right. So let's go. So we're going to go back to the OR. Everybody's in there. We got the patient well positioned, lights, anesthesia, instrument tables, all that stuff. And maybe urology is with us because you said you wanted to bring urology along. What would be your first step then in the OR
now? I guess my first step would be to see if I can do a better exam of her vaginal area and her urethra. And then I would likely perform a cystoscopy if I didn't already do one.
Good. That I think now, so the question here that comes up for Ebony is, are we going to evaluate the possibility of lower urinary tract injury first, or evaluate the possibility of intraperitoneal bleeding first? And that's going to be dependent upon your assessment of one thing in the OR. What's the important thing which determines whether you're going to immediately open her or whether you're going to take some time to look at her urinary tract?
Her stability, whether or not
exactly her stability. Yes, if she's got reasonable, stable vital signs, then probably we can take some time to do that. If she's decompensating, I think you got to open her abdomen because that kind of covers all the bases. You can look at the bladder and the ureters from within the abdomen, and you can manage any bleeding. So I agree. They haven't really said much about her stability. I think if we could evaluate the lower urinary tract, it's more likely here. So you said, how would you do that?
Via the cystoscopy or with opening up?
Okay, so we're going to do a cystoscopy. Okay, so we'll do a cystoscopy, and let's say there's no efflux from either one of the ureteral orifices that you can tell. What might you do next?
I would then place ureteral stents and see if I received any resistance.
Good, that's good. Now, in your practice, do you have experience placing ureteral stents?
Yes.
Good for you. Glad to hear it. Good. We were just having this discussion in morning teaching rounds with the residents, and I was working with the third year residents, and they had not, because they work on services with a lot of fellows, they hadn't yet gotten to place stents, but we'll be sure that they do. I'm glad that you have. That's great. So we're going to place stents, and that's a whole other discussion to sort of what we can learn from stent. But so we can move along here. Part D is, what is the management of bilateral ureteral ligation? So now they've made it very, very concrete. I think you place your stents, and we discovered that we hit a hard obstruction several centimeters up, and both ureters have been ligated in this case. So how should that be managed? And then we're done.
Depending on where the ligation occurs, it can be managed surgically by urology.
Yes, true.
And I would also, the patient would likely also get nephrostomy tubes placed as well so that they could
Very true.
divert the urine from going into
Yes,
the ureters and allow them
very
to heal properly.
Very good. In this case, we have to decompress the upper urinary tract immediately to avoid damage to the kidney. So you immediately place percutaneous nephrostomies. Your urologist would do that. Then what happens after that? At some point, we do have to try to get the ureters repaired. Can you speak even just basically to where we might go with that?
Depending on, again, where the ligation occurred, there
Yes.
might be the possibility to reattach the two ends together
Yes.
or to directly implant the proximal edge into the bladder.
Very good. Yes, exactly. I think we would do this probably at a later date if we put the nephrostomy tubes in. Although, I mean, if we are open in the abdomen, the urologist might actually want to go find the plate, get the sutures off right now, and do that. That would be correct also. Right, it would be what we call a ureterostomy, which is a direct end-to-end reanastomosis, like when they used to do tubal reanastomoses in the very old days. Or if it's within 5 centimeters of the bladder, very close, trying to mobilize the ureter and to reimplant it into the bladder wall, a ureteroneocystotomy. That's exactly right. And that is the level of information you would need to very handily pass this question, Ebony. First of all, noting that the important thing is to protect the kidneys. So we need to decompress them, so a perc nephrostomy right away. And then immediately or in a delayed fashion, depending on what else is going on in here, you would do a bilateral ureteral repair and exactly the way you described it. Those are the two options. Nicely done. Wonderful. Kind of difficult case. In your examination, and in your structured cases, you'll have about 8 structured cases. Maybe 2 of them will be of this level of difficulty. And the others will be significantly easier to get through than this. There's a lot going on here. I mean, that was nicely done. It was really well handled. Beautiful. Is there anything, just questions or anything you'd like to just check in about before we move on, and we'll see if one of our other candidates will do a case?
I know that they don't want me to consult. Like for the accreta case, I probably would have said, gyne to at least come and help. And then for
You
this
can
urology,
certainly say that as long as you're in the driver's seat and you're still, you're operating. Yeah. You can
yeah.
certainly say, hey, I would bring Yannick with me because I have it in my hospital, but immediately here's what I would do. Always have to talk about what you would do.
Okay.
Yeah, good work, Ebony. Thank you. That was really nice. We're 2 for 2 here. Would one of our other candidates like to step up? Please just click the raise your hand button and we'll work through. The next one is going to be an office practice case. It's likely to be a lower level of acuity than what we've been talking about so far. Anyone who would like to, please just raise your hand so we can move along here. I can also call on somebody. Tiffany, thank you very much for raising your hand. Get you unmuted here. There we go. Oops, I had you there. There we go. Hi, Tiffany. Can you hear us okay? And Maria,
Yes.
thank you for stepping up. Maria, we'll get you in just a second. Good. Tiffany, let's do office case number 1. 36-year-old woman states she has noted a left lateral breast mass for 2 weeks. Part A, what's our differential diagnosis?
If she was, well, I'd first want to see if she was recently pregnant or postpartum, and might be related to, like, it might be a breast abscess. If she's not pregnant, then like kind of on the more benign end, like a fibroma or a cyst. And then on the more concerning end, some type of malignancy.
Okay, sounds good. So let's run to that. So note again how undefined these questions are so that you can have a broad differential diagnosis. Do not know her pregnancy or lactation status. Do not know if it's painful or not, right? Don't know the size of this thing. Know nothing else about her. So you can get a broad differential diagnosis. So I like that you sort of went through, current or recent pregnancy and then on, because something like a galactocele or a breast abscess or mastitis certainly could be the case. So then you said under benign stuff, you said fibroadenoma. What else did you have there under benign issues?
Yeah, a cyst, or I guess she could have an abscess as well.
Cyst, abscess, fibroadenoma. That sounds good. Yeah, and then you should possibly malignant.
Yeah.
Got it. I think that covers some nice bases. I think that's plenty to have a really good discussion of this case. Let's move on. So what test will you perform?
Well, I think I would first start with the history and physical, and I would
Good. Good. Let's stop there for a moment, because that's how we should always start these cases. And note that they jumped you right into what tests will you perform. And honestly, as generalist OBGYNs, testing for breast issues involves only like imaging, like a mammogram and an ultrasound. We don't have anything else we can do. So I agree. I would do exactly what you did, Tiffany. I would back up and say, well, let's do a history and physical first. Good. So carry on. Here's where I want you to discuss sort of the specific of how you do a breast exam to evaluate something like this. So go ahead.
Well, in terms of doing the breast exam, I would manually palpate and kind of assess how large this mass is, and if there's any erythema, and if there's any tenderness or drainage. I'd also kind of look for things like retraction, skin retraction, and see if she has any nipple discharge. Those things would increase my concern for malignancy. If she's got any like lymphadenopathy in her adnexa, those would be the main things.
Good. And you want to keep our differential diagnosis in mind when we do this. So we think through all the things. So you mentioned things, inflammatory things like an abscess or mastitis, or it was meant right. You made sort of skin changes, inflammatory changes, local heat, stuff like that. Also the character of the mass, solid versus cystic, size, location, tenderness, lymphadenopathy, sort of the symmetric or asymmetric appearance of the breast. That is perfect. So now to tests. What tests would you order here for what's described here?
Well, she's a 36-year-old, so if it's a mass, then I would go for a diagnostic mammogram with ultrasound if needed.
Sounds good. Exactly right. Left diagnostic breast imaging mammography with contact ultrasound, I think, would be great. Great. Let's do that. Mammogram and ultrasound are negative. What will you do now? That's interesting. So we can feel something here, but the mammogram and ultrasound don't show anything unusual.
I would be inclined to refer her to a breast surgeon at this point.
Perfect. That's exactly the right answer. Now, there are two ways of going. Is there something else that you might consider doing if, it was not painful for her and you got back a completely normal mammogram and ultrasound?
If it was an abscess, I could potentially incise and drain it.
That's true, although that would definitely have turned up on a mammogram and ultrasound. So if your imaging is negative, so there's really nothing to go chase here, because your imaging doesn't point to anything. Referring her to a specialist, I think, is a perfect idea. That's what I would do. Is there any other option you could have, though, if it's really not painful for her and bothersome, and you really have negative studies on your imaging?
I think if she's comfortable with it and completely fine, then expectant management and interval follow-up to see if she's
good. You could do that. Yes, I think that's reasonable. How long would you wait to follow it up? I think is the next question.
Maybe about a month.
That sounds good. Yes, I think one normal menstrual cycle is often useful, sort of as looking physiologic changes in the breath, and enough time that something would circle around. And if you checked it again and your findings on the exam were the same in 4 weeks or in a month, what would you do then?
I would refer her to the breast surgeon.
Perfect. And you would have passed the question handily at that point. That's exactly right. We have a finding in the breast. We don't understand what it is. We have a negative mammogram and ultrasound. There can be things like cancers in there that actually can not show clear findings on mammography. This could be something else that's just abnormal about the breast, and it's really not showing up on imaging. A specialist is always right. And in the office practice case list, when breast diseases come up, this is one of the areas where we're not doing comprehensive management. Our job in the on the office practice case list for breast is either to be able to discuss the management of a breast mass or a unilateral nipple discharge. It's a history, a physical exam, mammogram and ultrasound, and no matter what, you refer on. And if it's cancer, you definitely refer on. And if it's abscess, you probably refer on to a surgeon to drain it. And if it's a fibroadenoma, you refer on to a surgeon. And if it's a galactocele, you refer on to a surgeon. And if it's just dense breast tissue, you observe it, and then you refer it on to a surgeon to be sure there's nothing hiding in there. So it's always refer on to a breast specialist. But Tiffany, that was perfect. That's exactly the right idea. And then again, in these questions, we're putting in some little curves and left-hand turns in here, so they're sort of unexpected as we go through the question, because they turn up very commonly there. And when they give you part C, they're waiting to see which candidates will sort of drop it and go on and not worry about it, which is not the best thing to do, and which candidates will sort of stick with it and move to the next level up, which is always the right thing to do, and especially when we have the breast involved. You hit that one on the head. That was nice. Good job. Tiffany, any questions or anything you'd like to chat about here before we go ahead to Maria?
No, thank you very much.
That was great. Wow, another 3 for 3. Let's go to Maria. Hi, Maria. Can you hear us okay?
Yep. Can you hear me?
I can. Yes, thank you. We're going to circle around to an OB case, I think, coming up next here. Let's see here. So we've got a 30-year-old woman at 31 weeks gestation presents with regular preterm contractions and 50% cervical effacement. Discuss the management of preterm labor at this gestational age and in this situation. Part A, how would you evaluate this?
As always, I would start with a history and physical. I would put her on a monitor and toco.
Good.
And after doing the exam, I would have collected a fetal fibronectin, pending the rest of the exam. But I suspect if we're at 50%, knowing that there's certain criteria for the FFN, and potentially send that off. And that's how I would at least start the evaluation and continue to monitor for the patient for the progression of her contractions or changes in her cervical exam.
Okay, it's a nice start. Is there anything else important that you might want to determine that you haven't actually mentioned yet that we would check for here? So she came in, we don't know anything about her history. Again, a lot of this is undefined. They don't tell you anything about the exam aside from 50% effacement. Anything else that sort of could be going along with preterm labor that maybe is why she's having preterm labor?
Oh goodness, yeah. I mean, it's always the obvious stuff that you forget to kind of verbalize.
It is. Yeah.
Yeah, so during that, the history and physical, you want to find out if she's had prenatal care.
Yeah.
What probably, if there are any precipitating events prior to the preterm labor, if there's any substance abuse, medication use, if there was any potential trauma, and all that would play into the history and physical. Find out if there was a history of this in the pregnancy, if this had happened in any previous pregnancies. If she's been seeing a high-risk doctor for this, if she's been on any medication for this.
Good. Now that's perfect. I think that's excellent addition. What I was thinking of in particular is when you are doing your exam, you're doing the cervical exam, you're getting the free fetal fibronectin. Is there any other condition that commonly co-presents with preterm labor that you'd want to be sure you exclude or identify if it's present?
Preterm dilation or?
Well, she might be dilated, just says 50% effacement. Anything else that should go along with, that could cause somebody to go into labor at 31 weeks, that's also important to know. And on your vaginal exam, you would seriously be looking for it. If I was standing behind
you always want to, you want to make sure that you have correct dates?
Well, that's true too, but particularly you're doing your vaginal exam, you're looking into the vaginal vault. There's something else that you're looking to either see or not see in there that's really important to.
Is ruptured. See if there's
rupture membranes, PPROM. Yes,
that's the easy one.
Yes, yeah, exactly. That's the one thing you don't want to miss here, because where this question is going, the management of preterm labor now is very different from the management of preterm labor in the setting of PPROM, right? It didn't used to be that way, but it's a whole different protocol. So that the decision point right here is she preterm labor with PPROM, in which case you're going to treat her as PPROM, or is she preterm labor with intact membranes, in which case she gets treated in a whole different way now. So that was the one important thing, yes. And if I were standing behind you in the exam room, I would see you automatically check for this without even thinking about it, but we just have to verbalize it. That's all. Good. So that's good. The other important thing to remember, of course, is that we have two patients always in obstetrical cases. So you did mention that you're going to put the patient on the monitor. It's good to mention just briefly, in addition to sort of looking at the toco, what else you're checking on the monitor?
The fetal heart rate.
You're looking for fetal heart rate. Yes, exactly. Good. And again, obviously, just vital signs also, febrile, hypertensive, anything like that. Good. Part B, what antibiotics would you give? And again, this kind of comes out of left field because intact preterm labor, there's not an antibiotic protocol anymore, but this is something important to consider.
Well, if she is intact and she's in preterm labor, and I'm concerned that she is progressing and going into labor, I would consider penicillin for GBS prophylaxis, as I would assume.
That's exactly the answer right there. That's exactly right. Yes. Yeah, exactly. She is. I'm certain unknown GBS status at this point. You would definitely do that. The other way you could address this, and in the structured cases, because you drive the case, you could actually go into talking period. You could say, well, we haven't determined whether she is ruptured. If she is preterm labor due to PPROM, here is what I would do for my PPROM antibiotic protocol. And you could just go that way, and the examiners will let you go that way. And as long as you don't say anything untoward, you're doing fine. Or you can just stick with what we have here, which is there's no mention of ruptured membrane. So it really is just GBS antibiotics. Good. Now, really important question. Under what circumstances would you administer tocolysis to this patient? This is important to review for the exam.
Yes, it
There
would be a very good
there's
topic.
only three things that we want to think of. They're basic categories of when we might administer tocolysis.
So we want to make sure that there is no signs or concerns for infection. If you are administering betamethasone and are attempting to get the full 2 doses of steroids administered.
Good. So are you saying that you might administer tocolysis in that setting?
You could consider it. I don't necessarily normally do that on a routine basis.
Okay, it is permissible, right? And criterion number 1 is short-term tocolysis, 24 to 48 hours, to allow time to optimize the fetal status for an impending delivery. That's how they state it. Yeah, so at 31 weeks of gestation, it would definitely be, if we thought delivery was going to occur in the next 24 to 48, betamethasone. Anything else we'd be doing as far as optimizing fetal status at 31 weeks?
Well, if we're considering doing the betamethasone and the patient is unruptured and patient is under 32 weeks, so you would administer magnesium sulfate for neuroprotection of the fetus.
Got it. Exactly. That's exactly right. Yeah. So I think it's possibly betamethasone, possibly neuroprotective magnesium sulfate, GBS prophylactic antibiotics. That'd be great also. So that's one reasonable indication for tocolysis. Can you think of another indication for maybe short-term tocolysis that might help us in this case, not related to what we just discussed? There are 2 more things that are listed in the ACOG materials and practice bulletin on this. And they only pertain to patients in certain circumstances.
Oh boy, I don't know specifically, but my mind is wandering to if you are I don't know, like in an event of like the patient needs a C-section and you're trying to sort of delay that from occurring.
Yeah, that's true. I think that's actually that's a good one to consider also. That's sort of about optimizing status too. We're thinking about things for which short-term tocolysis might buy us some time to sort of do other things that would help the patient and the fetus. In your hospital, what level of NICU do you have?
That's a good question. I have 2 of them and they're both level 3.
Oh, good. Okay, great. If you're in a hospital with a level 1 NICU, would that raise in your mind any reason why you might consider short-term tocolysis?
Oh, yeah. So you need to stabilize the patients so that you can transfer them to a facility.
That's it. Number 2 is to buy some time to transfer the patient out to a higher level of either maternal care or fetal care or both, depending on the circumstances. Exactly right. Good. There is one more that sort of turns up here, and that is, suppose this patient had, you on your workup, you figured out this patient actually had a really developing pyelonephritis, and maybe that's why she's going into preterm labor.
Oh, to stabilize the mother and then allow for delivery once the mom is stabilized, or
it's to buy some time to treat an underlying medical condition, which if it were treated might resolve the preterm labor. And a pyelo you could think of a number. A pyelo definitely comes to mind. If you did 48 hours of antibiotics, I bet her preterm labor would subside and you could continue the pregnancy maybe for a very long time. So those are the 3 things to remember for the exam. Short-term tocolysis to optimize fetal status for delivery, sort of, just all the medications we talked about in administrations. To transfer to a higher level of care if we need to stabilize the patient for transfer, and maybe to buy time to treat some underlying medical condition, which if you could treat that, might dramatically improve your management of preterm labor. Exactly. Let's see, and there's one more. Let's see, what other treatments would you consider and why? You already answered this because I think they were thinking about the neuroprotective magnesium sulfate. I think that was the one. So I think you got your GBS antibiotics. That's at this gestational age. That's really it: betamethasone, GBS antibiotics, and neuroprotective mag. That's it. All right, that was nicely done once again. We have enough time for one more case. Maria, any questions or anything you'd like to ask about this before we move on? And maybe we'll get one more in.
No, I mean, it seems like for these structured cases that we can kind of drive it either way, and they would probably stop us if we go in a direction they don't want us to, is my assumption.
That's true. Yeah, they would redirect you, but you can actually sort of, as long as you're making sense, you can sort of take the case and make of it what you want to. And as long as you describe appropriate management for what you are making the situation into, you're fine.
And I mean, missing something like rupture of membranes, which I know,
Yeah.
but you know, when you're in that situation,
They would prompt you as I did. They're not out to lead you or give you clues, but they would say, "Are you sure there isn't anything else?" And about the third time they say that, what you should say is, "I know you're trying to get me to think of it something. I can't think of it right now. Could we come back to it in a minute?" It's always the proper thing to say. And they will, if it's important, they will come back to it. Usually, my experience in the exam, because it happened twice, is I said that, and within 15 seconds, they had me talking about something else, and it just popped right into my mind. Because as soon as your mind redirects, it sort of uncovers, and you say, "Oh yeah, PPROM." But that is always the thing to do. Always allow that you're not thinking about it, and give them the opportunity to sort of let you think on it, and you'll get it. Good, nicely done, Maria. Thank you. Let's see. We have time for one more case. Would any one of our candidates like to put up their hand? Let's see. I think Dr. Robinson is the only one who hasn't gone. Dr. Robinson, if you'd like to, just raise your hand and I'll call you. Otherwise, if Dr. Robinson does not step up, anyone of our candidates who has gone already can have a second round, and we can do a double team if you'd like to do it with somebody else. This will be a GYN case coming up, by the way. Okay, Dr. Ben. Let's get Dr. Ben up. Ashley, welcome back again. Let's see, and anyone else who would like to, anyone else who would like to pop up? Let's see, Maria, do you want to stick in and still continue with this with Ashley?
Sure.
Okay, all right, you two do it together. Here we go. 62-year-old woman is referred from her family physician with a 5-centimeter simple adnexal cyst by ultrasound. She is asymptomatic for this finding. All really key information. Part A, what is your differential diagnosis? So differential diagnosis for a 5-centimeter simple adnexal cyst in a 62-year-old woman, asymptomatic.
Sure. So obviously a persistent simple adnexal cyst. So,
yeah, exactly. Great. What do you think?
Sometimes I would find it unlikely that a simple appearing mass, it could be a paratubal cyst. It could be something not even relate on the gynecologic organs at all. Maybe she had a complex abdominal surgical history and was some sort of
that is true, but honestly, this is the obstetrics and gynecology oral exam, so they want you to kind of focus on the GYN stuff first. I think I absolutely agree where you're going, and that paratubal cyst or hydrosalpinx is really important because I would put that in my differential. But let's stick with stuff that's primarily gynecologic.
Okay. Well, and you gave me one at the hydrosalpinx because that's kind of
sure
different.
Yep.
Always in the back of your mind when you're looking at an abnormal finding or a significant finding on imaging, you're worried about malignancy in the back of your mind.
Yeah, good. That's a good way to put it. Yes. What else could this be? What would you say is the statistical likelihood of this being malignant, just in general?
I would say quite low.
Low, I think 1% or less. I think good. Yeah. But it's important to mention it. Anything else you'd like to mention? I know otherwise nobody's actually mentioned the ovary yet. We talked about paratubal cysts and hydrosalpinx and some abdominal surgical stuff. Nobody's touched the ovary yet. Anything about the ovary that we should put into our differential diagnosis?
Concern for torsion?
Okay, but she's asymptomatic.
True.
Could be, yeah, sure. Could a 62-year-old have a 5-centimeter simple cyst that really is just sort of an okay physiologic cyst and is not dangerous to her?
Yes.
Absolutely.
Yes, absolutely. It could be. Yes, absolutely. I've met a number of women this year so far who have had that. Yes. So what else should we think of here? Maybe we'll broaden our differential a little bit more. Any other sort of basic categories of cystic findings on the ovary that we should think of? We talked about physiologic stuff and tubal stuff. We touched on malignancy, which is a third category over there. There's sort of a second category in the middle I think we might want to talk about.
I mean, it's simple, but I guess it could be like a cystadenoma.
Yes, a benign cystic neoplasm of the ovary. So with that adnexal masses in the exam, the three categories that we should talk about, and if you can name one or two things from each category, you've got like 6 right away, is physiologic issues, benign neoplasms, and possibly malignancy. And as generalists, we want to keep the discussion over toward the physiologic and the benign because that's what we deal with. So Ashley did a really nice job. You sort of mentioned cancer and then you bounce off it and bring the discussion back over to what we see every day. So in a younger woman, yeah, everything endometrioma might be in there. Several corpus luteum cyst, simple cyst of the ovary, hemorrhagic cyst. Simple cyst in this woman. So for cystic neoplasms, you had cystadenoma, definitely possible. Malignancy is out there, although unlikely. We sort of want to just acknowledge it and then kind of get the discussion away from that stuff. And let's see, as far as benign neoplasms, anything else we should think of in there? We can be done and move on if you're good to go. Is there anything else you might want to mention before we go on? I think you have a good differential diagnosis. I think serous or mucinous cystadenomas, I wouldn't want to touch germ cell tumors because they tend to be more solid, and I don't want to talk about those in the exam anyway, so I think I would stick with what we got. So how will you evaluate this presentation?
Sure. So, of course, starting with the history and a physical, has she ever had cysts in the past? Is she having any bladder issues, any postmenopausal bleeding, any, we always look at the worst things. So any sudden early satiety or bloating, of course.
Good.
And then do an abdominal and a bimanual exam.
There you go.
To see if we can palpate this.
Perfect. And tell me briefly, sort of like we talked about the details of the breast exam, but that nexal mass is how we characterize it on examination is important. So tell me what particular features you're looking for that you can distinguish on a bimanual pelvic exam.
So
I'll start you off. Size for one, right? You can tell roughly how big it is and whether it corresponds with the ultrasound. Aside from that, what else can we learn by palpating this thing?
So size, contour, does it feel hard or is it more, soft and simple feeling?
Very good.
Yeah, I'd say size, contour, shape. Is there anything? Are there any other masses or any other abnormal findings on a bimanual exam?
Yes. So anything else important besides size, contour, sort of consistency, sort of soft, hard, firm. Anything else is important, sort of when you're pushing around it, that might help you to characterize it.
Pain.
Oh, that's true. Yes. Is there any pain or tenderness? Any symptoms? Yes. Anything else? One other thing, maybe.
Like mobility of the
mobility, yes. Is it fixed or mobile? That turns you in one direction or the other, especially if you're trying to figure out whether to watch this or whether to operate on it. Exactly. I think that's exactly right. The size, the consistency, sort of the feel of it. Is it mobile? Is there anything else sort of invested with it or attached to it? Is it in any way tender? Any abnormality of any other organs? I think that's great. Now, let's go back to its sort of history, physical examination, and now testing. What we have is this one ultrasound that the family physician sent over. Is there any other test results that you either want to get or maybe go back and look for from the past that might help you here?
So she's been getting care in my health system and I have access to her previous radiologic findings, see if she has a previous pelvic ultrasound or a CT, and see if this has been here for a really long time or if this is a new finding.
Exactly. New or persistent finding. And if it's persistent, has it changed over time? Was it 3 centimeters and simple, or 2 years ago? Exactly. That's great. Good. Let's go on to number 3 here. When would you manage this case surgically? This will be the end. And there's a brief list of things we want to talk about as far as sort of red flags that would take us to recommend operating on it rather than just sort of watching it for 12 weeks and checking ultrasound again.
So if she's encountering intermittent pain and there's a concern for torsion with this, would be a reason to manage it surgically. If over time this starts increasing and maybe just causing her pain or anxiety and she doesn't want to think about it anymore, you could certainly with consent do that. If it gets beyond 10, sorry, go ahead.
Yeah, go ahead. No, you're hitting something really good. Go say what you just said.
I believe typically in postmenopausal women, if this cyst continues to look simple, it can be managed expectantly up to about 10 centimeters.
It can.
No problems whatsoever.
Size is good. Yeah. So let's continue with what Ashley's doing here and Maria, jump in here also. We'll get Tiffany in here too because she's got her hand raised. So let's get Tiffany up. So I think maybe a handful of things that we should think of now as far as indication for operation. And then if we decide to observe this, what are the handful of things that we would observe over time that would lead us to then change our plan to go operate? So size, I think 10 centimeters is a good cutoff. In a woman of this age, 10 centimeters or more, absolutely she's going to the OR. Symptomatic in any way, doesn't have to be just pain. If she is having symptoms related to this, she should go to the OR. What else? That's 2. And there are generally, I think, 5 things we should think of. So we got size, we got symptomaticity.
Any characterizations that might change on the ultrasound that would make you concerned?
Yes, exactly. If it's not simple, if it's complex, suppose it's multiseptate, suppose it has excrescences or mural nodules or heterogeneous features, or maybe it's partially solid. Yeah, complex rather than simple, anything like that. That's 3. I think we just need 2 more. And now is when we're sort of getting into things that would indicate cancer.
I guess any other findings on imaging that would be concerning for malignancy, I guess.
Exactly, yes. That you just said it, features suspicious for malignancy of any kind. And they could be some of the stuff we talked about or the presence of abdominal ascites or something else like that. Exactly. And then there's one other thing we haven't talked about, and this is not in this question, and that has to do with, would you be getting tumor markers on this woman?
I personally wouldn't, but I feel like a lot of
that's fine. She's asymptomatic. You mean you could, if you got tumor markers and you got a positive tumor marker, how does that now change your management?
Well, then I feel that you're sort of kind of pigeonholed into possibly having to well, you wouldn't want to remove it because I am a generalist, so I would consider a referral to a gynecology oncologist.
Exactly. If you do a tumor marker and it turns up positive in a menopausal woman, you have to send her to GYN and she's going to get surgery. That's exactly right. So one of the criteria for operating on this is if you happen to be handed a tumor marker that this family physician did, and it were in any way questionable. So it's really the size, the size, symptomaticity, the character of it, so especially complex, any findings suspicious for malignancy, and you have a tumor marker that's positive. Now, very briefly, and then we'll close for the evening, if we decide to watch this for 3 or 6 months, what sort of things might now turn up on our observation that would lead us to operate on it? And it's sort of 5 things again. And it's much of what we just went over. An exam, this is what you want to talk about. What 5 things would make you operate on her now today? And if you watched it, what 5 things would make you decide somewhere down the road it's time to operate?
So first of all, we just question: is it similar to like everything that Ashley had mentioned about any change in pelvic pain? I guess early satiety, nausea and vomiting, things like that.
If she's asymptomatic now, if she becomes symptomatic over time, she goes to the OR. Yes.
Yeah.
Let's see. I think one of you mentioned size.
Yeah.
If we watch it over time, if we watch it over time, it's 5 centimeters now. If we watch it over time, related to size, what would make you decide to operate on it?
I guess if it reached the 10 centimeter.
I think, if it enlarged, if it's 5 centimeters now and 6 months from now it's 8 centimeters, would you think about operating on her? It's an enlarging adnexal mass in a menopausal.
I would be strongly considering operating.
Yes, exactly. So she becomes symptomatic, the size increases. It's simple right now. What over time might change in that respect that would lead you to take her to the operating room?
Any ultrasound findings concerning for complexities, the excrescence?
Exactly.
Yeah.
It goes from simple to complex or anything more. She now has no findings suspicious for malignancy as far as we can tell. What over time would make you decide to go ahead and operate on her?
If she was done with the expectant.
If she developed findings suspicious for malignancy over time, yeah. And the 5th one, I think, is if we got a positive tumor marker. Let's say you got tumor markers now and they're normal. If you continue to observe this over time, what finding regarding a tumor marker would lead you to operate on her?
35 or higher.
Yeah, sure. Yeah, a positive in a menopausal woman, right? Whatever tumor marker you picked, any positive tumor marker. So it's really the same 5 things. It's just sort of change over time. So we agreed the size now 10 centimeters, she goes to the operating room. If it's the way it is right now, you watch her, it increases, you go to the operating room. Same with the symptomaticity, the simple versus complexity, feature suspicious for malignancy, tumor marker that pops up positive. Yeah. Those are the 5 things that we should just write down and remember for the exam when this case comes up, because there's always a case just like this in the exam. You'll be ready to go. When they come to part 3, you can just rattle off those 5 things and you'll be done. That's exactly what we want to know for the exam. That was very nicely done. Thank you, all of you. We do need to stop for the evening. They're going to cut us off in just a few minutes here. Are there any questions or anything that we should talk about just from any of you so far? And we lost Ashley. Let me see if I can get Ashley unmuted here. There she goes. She's back. Okay.
I don't have any questions.
Oh, okay. All right. That's fine. Great. Good. Tiffany, okay?
Yes.
Great, thank you. And Ebony, thank you again for doing that. Maria, thank you for doing that with us as well. So we do need to close down for the evening. As a reminder, these are all archived on the ExamPro website. As subscribers, you may come back and listen to these at any time if you want to go back and take notes on something or just review anytime between now and your examination. In fact, we will continue on. We're on our regular schedule next week. Sunday and Tuesday are case list defense for all of you with your case lists. Monday and Wednesday will be a whole new set of structured cases. And I believe I'm meeting with you next Sunday. So I will look forward to you at our next meeting, getting together with you. Have a great rest of the evening, everyone. Thank you very much for joining us this evening, and we'll sign off.